Welcome. So this is the last session of U.S. health policy, and I'm joined today by, I'm John McDonough, the person you've been seeing for a while. And I'm joined by someone you haven't seen, Martina Skowron, one of our three phenomenal TAs for this course. Our other two, Melissa Majoral and Caitlin McMurtry, are both in DC and so couldn't join us today, doing great work down there. So this is the final session. If you want to, if you have a burning question that you feel like you need an answer to, we're doing this live, 1 p.m. Eastern Standard Time, Thursday, June 12th. So if that's you right now, thereabouts, then feel welcome to go online and give us a question. Martina and our faithful techie, Steve Alardi, is going to be, will be shooting questions out at me as we go along. And I also have some things that I wanted to share that if I knew, if I'd had them readily available back when we were doing some of the lectures, I would have included them, but some things that have happened. So what I'd like to talk about is I'd like to talk a little bit about where are we on the Affordable Care Act right now? What does it look like? Where are we going? What are some of the big system challenges ahead that I and other people see? How can you engage in health policy if you are so motivated to, by your engagement with this course, you'd like to get involved? So we have some ideas. And then thinking about some of the other bigger issues that aren't seen as healthcare issues, but that do in fact involve health policy moving forward that are very much going to be part of our future. So those are some of the things that I'd like to get to in the next roughly 60 minutes with Martina. And so I will do some of those, and then you guys can shoot questions at me, and we'll take it that way.
Sounds like a plan.
Okay. So I want to start with a couple of slides that I think are compelling. So first one up is slide number 2, which is health spending per capita, 2011. You've all seen this slide before. It's a little updated, but it's the U.S. on a per capita basis compared with all the other countries. And this should be very familiar to you. We discussed this in the very first session. And this is health spending per capita. And what you can see is just how much more we spend from country number 2. And there's different ways that gets counted. Generally speaking, number 2 is always either Norway, Switzerland, the Netherlands, Germany, one of those countries. Here it's Norway and Switzerland are very close, okay? So that's important, just to know how much more we spend. But I'd like to jump, if we could, to slide number 3. Slide number 3 is a fascinating slide based upon analysis that was put together by Professor Elizabeth Bradley, Betsy Bradley from Yale. And she looks at this issue of how much we spend on medical care in a different way, because what she does is she looks at both health spending per capita, or however you choose to measure it, but then she also looks at, so how much do all these other countries also spend on non-health related social services like childcare and job training and other kinds of human service needs that don't fall into the circle of medical care spending. And so if you look at the left hand of that slide, it shows it pretty well. The bottom darker part of the line, that is medical care spending, and the upper grayish line is non-medical, non-health social service spending. So what you should be able to see if you look at that slide is the United States. We're no longer far over on the left, we're more in the middle. Now if we were scaling the line based upon medical spending, you can see we are still far and away number 1. However, what you should also notice is that for the gray part, the social service part, which oftentimes gets at what we call the social determinants of health. Those of you who took Ichiro Kawachi's course on the social determinants of health will know what we're talking about. on non-health social service spending, we are the biggest cheapskates among all of these countries and far below the OECD average. You can see right in the middle the OECD average. That's the measure of all of these countries. So the OECD average on non-health social service is 16.9%. The United States is 13.3%. So you put both of these measures together, and you create the chart that you see on the left. And what you see is that the United States we're no longer the big spender. We're bigger than average, but we are significantly below some of the more expensive countries in terms of what they spend on both combined. And so when we look at, for example, some of the significant public health measures around infant mortality, life expectancy, low birth rate, frankly, improving those is less related to the dark part of the line and more related to the gray part of the line. And so, again, this is just another way of looking at and understanding the realities of what we're doing. You know, part of the message of this might be that perhaps if we spent less on health services directly and more perhaps on social services, might that in fact bring us to better outcomes in terms of what we want. So anyway, that's important. And then let's just jump to one other slide, which is a variant, slide number 4. Oh, that's not the one that I gave you guys.
Slightly different.
What's that?
Slightly different.
Oh, okay. Well, you've seen this slide already.
Yeah.
What I had was an OECD slide. What happened to this one? It got taken out.
Yeah.
It showed many more of the OECD countries. It was a bigger, tighter wad of spaghetti with the U.S. still out of it and stuff. So you look at this and you look at our public health measures, and that gives you a portrait anyway. So let's go to some questions. What have we got?
Sure. I think a lot of folks are really interested on the impact of the ACA and what we can expect both now and then within the next 10 years. Access, quality, outcomes, cost.
So where are we on the Affordable Care Act? We are going through seismic change. We're going through a period of climate change, rapid climate change on the ACA. I see right now. There are several things that are happening that are related to this. In particular, we start by looking at access and what is happening in terms of insurance coverage. And if we can jump to, Steve, if we can jump to slide 7. How many are benefiting from ACA coverage? This is pretty much the best we know in terms of estimates of on enrolling in public or private health insurance, how many folks have actually been helped. So what we know from the federal government is that about 8.2 million have enrolled in new private health insurance through the health insurance exchanges or marketplaces, the same thing, both federal and state. Okay, so that's point number 1. Point number 2 are 5 million, an estimated 5 million who also enrolled in private health insurance during the open enrollment period from October 1, 2013 through April 15th, 2014. And the estimate is about 5 million Americans enrolled in ACA qualified plans outside of the exchanges or marketplaces. So they might have gone directly to WellPoint or United Healthcare or their Blue Cross plan and just bought directly, and they didn't get any of the subsidies or the cost-sharing protections. So they tended to be people who were higher up the income scale, but still it's a significant number. And then we also know, and this is data from just about 2 weeks ago from the U.S. Department of Health and Human Services, that we have seen during that period from the fall through now to mid-April an increase in Medicaid and the Children's Health Insurance Program of 6 million new enrollees. So we had about 59 million. We're now up to about 65 million as of the early spring. So that's an increase. And then we also know finally that the best estimate is about 3 million folks have enrolled in their parents' health insurance policy under the ACA provision. that actually went into effect in 2010. So you add all those up, and that comes out to about 22.2 million total people have enrolled through any of these. Now, here's what we don't know. We don't know yet conclusively how many of those 22 million were previously uninsured versus how many had insurance and were switching to something else based upon the revised eligibility. So we still have a lot that we need to know. We also don't know how many individuals have newly enrolled in their employer's health insurance plan because they were motivated to do so by the individual mandate. We knew that was a significant number in Massachusetts. We had one estimate on that, and that came out in March, and that was from RAND. And RAND estimated there were about 9 million people who newly enrolled in their employer health insurance plan during this open enrollment period. Now, honestly, we haven't seen that confirmed anywhere else. Most folks kind of think that that is kind of way high up off the charts and is not reliable, which is why we didn't really put it here. We will find out later. But the question, the burning question is, of those 22.2 million, how many of them are thus a reduction in the rate of uninsurance? How many were not uninsured? We don't know. We have colleagues here at the Harvard School of Public Health, some of whom you've met, who are working very hard at that number and are going to be publishing a paper sometime in the near future. Not at liberty to give you that number at this point, which they're still checking. But we can look at some other data that we think may be helpful. And if we can go to slide number 9, Steve. Slide number 9, this is from Gallup. They are doing regular surveys of the uninsured on a month-by-month basis. And this is their most recent data, which you can see if you go over to the far right. You go from the dramatic number of, in the early fall of 2013, 18% of Americans without health insurance. And by the early spring 2014, we're down to 13.4% of Americans without health insurance. That's a dramatic drop. If you want to know what was going on during the period of that time, of that dramatic drop, that was the open enrollment period. And let's jump ahead then to slide number 10, Steve. And this breaks the Gallup data down into better categories so it can help you understand a little bit of what's going on. If you just look at the right-hand column there, what you'll see are some really telling data, particularly if you go halfway down and you look at the drop in uninsured by ethnicity, and you see white uninsured rate dropped 3%, black 6.2%, Hispanic 5.6%. Understand, among America's uninsured, slightly more than half are racial and ethnic minority groups, are folks from underrepresented minority groups. And what we see here is a disproportionate enrollment by blacks and Hispanics. That is what we would want to see because they represent most of the uninsured. So in addition to dealing with the problems of health, we can already see that we're starting to get to greater equity in our healthcare system.
So I have an interesting question that's coming on the fly, which is, people have enrolled, but have they actually utilized the insurance?
So we're starting to see indicators and data from that.
Can you repeat the question because I'm a little
Okay. Oh yeah. So the question is, what are we seeing already in terms of people's utilization? It's mixed. There were many predictions that when people enrolled, provider groups. You're a provider now. She works at Brigham and Women's Hospital. There was going to be this mad rush of people going in and getting services. We are hearing some reports that around the country there are some emergency departments where we're seeing some real spikes, but we're not seeing otherwise hospitals or physician organizations, physician groups or practices saying they're being overwhelmed with new enrollees. We are seeing some of the important safety net provider hospitals around the country saying that they are seeing significantly increased revenues because people now coming through their doors have coverage. The other piece, and that leads to one other piece on the chart, which is look at the bottom part and who is enrolling based upon their income status. And what you see is for families with household income of under $36,000, 6% drop. 90,000 and more, that's over 4 times the poverty level, a drop, but a drop of under 2%. Again, that is what we would expect to see and what we would want to see, because we know that uninsurance is far more concentrated the lower your income is rather than the higher, and so this is exactly what we want to see. So this is the portrait. This is at least one rapidly developing portrait of what we're seeing going on right now because of the access expansions under Title I and Title II of the ACA. We also want to talk about the delivery system reform pieces, but let's hold on with that. We'll get to that. Let's take another question.
Okay. Based on the changes going on in our healthcare system, what kind of new healthcare companies or investments do you think are the most promising?
What do you think?
I think we're seeing a lot of innovation. I think there's a lot of innovation on the provider side. I think there's a lot of innovation with new technologies really shaping. There's a lot of innovation with getting folks enrolled and really allowing them access. So I've seen it across the spectrum. I don't know. I work on the provider setting, so I'm generally more in tune of what providers are doing and different companies entering into that space and helping with medication adherence, but really helping to provide better care.
Yeah. The other thing, that I've heard, and again, I don't have the data here to pull out, but in terms of sort of the stock market performance of healthcare companies is doing significantly better, but significantly better in the managed care companies and the insurance companies and the hospital chains in the states that have expanded Medicaid. And in the states that have not expanded Medicaid, some of the hospital chains are facing some serious financial difficulties because the forecast ahead is less money from the federal government for caring for the uninsured because their numbers are going down. And if you have not expanded Medicaid, you're seeing far less than benefit from the ACA. So increasing pressures and increasing tensions in the non-Medicaid expanding states.
The work, I was just going to add to that. So the work that I've seen, I think I've seen a lot of stakeholders enter into areas that they're not normally have been working in. So for example, I think insurance companies have been able to provide a lot of innovation and a lot of perspective on the analytics that providers need to better serve patients. I think the way you talked about disease management, we don't currently have the right data infrastructure, but we know that insurance companies do. So I think they're now also innovating in areas that they historically have not.
Yeah,
in terms of data.
A lot of change going on. So let me just show a couple of slides. So let's look at slide 12. So you remember when we talked about delivery system reform, our quality week, and in lecture 2 when I talked about the accountable care organization, the accountable care organizations, ACOs, as one of the toolbox of delivery system reforms. In fact, let's back up to slide number 11. So, by the way, this was this idea of the toolbox. I have to credit that. That's David Blumenthal from the Commonwealth Fund. They wouldn't let me, the powers that be wouldn't let me use his slide, but they gave me my own toolbox to use. So I had to put my name on it or something like that. But you think of Title III and the delivery system reform and other parts of the ACA as a set of tools to try and address the inefficiencies, the poor quality, the lack of the optimal quality care as challenges to be addressed within the ACA by this toolbox. And here are a set of the tools. You can see over on the right, value-based purchasing, ACOs, hospital reporting, patient-centered medical homes, and on the left, bundled payment, the bonuses for Medicare Advantage plans. These are all part of the tools. So let's just look at a couple of them. So let's go to slide 12. Here's what's going on with accountable care organizations. Accountable care organizations are just providers. They are physicians groups, hospital systems, home health care organizations, post-acute, long-term care. Any combinations come together within the Medicare program, and they assume risk to take care of a patient population. When the ACA was first passed in 2010, and people said, well, what's in there to do medical delivery system reform? People would say ACOs. And the charge back a lot of times is, well, you know, ACOs, they're kind of like unicorns. I mean, we know what they look like in theory, but we've never seen one in real life. And similarly, so an ACO was like a unicorn. But look at this chart, no more. Look at the growth of ACOs, some of them related to hospitals, some related to physicians and others. You put those two numbers together, that's almost 500 ACOs just in Medicare. We're also seeing ACOs right now emerge on the private side as well. And what's the point of the ACO? The point of the ACO is to move providers away from predominant reliance on fee-for-service reimbursement that rewards quantity and volume of services provided and toward value-based, accountable, capitated, whichever version you want to use, reimbursement that attempts to reward based more on efficiency and effectiveness and quality rather than volume. So here we see the growth. But let's jump ahead to slide 14 and look at something really dramatic that's going on. One of the pieces of the ACA in Title III that took effect in 2012 were new penalties on acute care hospitals which had excessively high rates of readmissions within 30 days for Medicare patients. We started really keeping this data in a systematic way in 2007, and you can see between 2007 and up until about 2011, late 2011, not much motion, staying within that margin. And then look what's happened since 2012. It is going down in a way that was hoped for by this incentive or penalty, whatever you want to call it. You can call it either one validly. But so, and again, now you look at the actual number, we're going from up around 19% plus down to about 17.5%. And so you might say, well, big deal, what does that matter? Well, let me tell you what it matters. What it matters is it's about 160,000 not occurring readmissions, just over a 12-month period that equals potentially about $4 to $6 billion in savings in Medicare just from that one change. So that's a significant piece. Yeah.
Yeah, I'd just like to add to that. So the way that this is looked at for providers is going back to John's toolbox. Medicare started paying effectively for hospitals that were reducing their readmissions. So it was one of the quality metrics within the value-based purchasing system that if hospitals were performing effectively, they were getting the full amount that they should be for these conditions, whereas if they weren't, they were getting penalized. So it's really had a huge impact. Not only do they report, but really incentivize hospitals to get better at performing within this.
It's good news and it's, bad news, but I mean, when you pay to do things, sometimes you actually get surprisingly positive results. Let's look at another one if we go to slide 16. This chart shows you some data from the Centers for Medicare and Medicaid Services. There's also new data from the Centers for Disease Control and Prevention on decreasing rates of what are sometimes called hospital-acquired conditions, and including infections, including falls, including other kinds of issues. And you can see 4 of them here. These are changes between 2010 and 2013. Now, there are penalties on hospitals, again from Title III of the ACA, for hospitals that have excessively high rates of hospital-acquired infections. And we can see under the ventilated associated pneumonia, that's connected to that. The others are less so. But we are seeing, for the first time since we've really become concerned about quality, we are actually starting to see the healthcare sector go in the directions that we want in terms of the quality measures. We had these major reports. They were talked about during Quality Week, crossing the quality chasm. and To Err is Human, the big reports from the Institute of Medicine that put out a clarion call for changes in quality. And 10 years or so after the release of those reports, the analysts went back and looked at how we'd done, and all of the analysis came up saying a lot of activity, and we're not seeing any results. We're now starting to see results. It's really exciting. So anyway, so things going on that are quite positive, that are related to the ACA on access and on moving the needle on delivery system reform.
So I think that you sort of hit this up, but this question sort of pulls in on that, which is, what are your thoughts on consumer cost transparency tools to compare the cost of procedures that include quality data for the providers? How do you think the cost and quality comparison tools will impact provider costs?
So 10 years ago, there was very little that was really available if you wanted to find out what was going on and how well your hospital or your physician matched up. Believe it or not, that has changed enormously over the past years. Just two. And these are both federal measures. There's Hospital Compare on the CMS website and Physician Compare on the CMS website. You can go and you can see on a host of measures how well your hospital that you prefer matches up with other hospitals in your area. You can get data on your physicians. And there are other sources as well outside of the government. There are all kinds of sources. Arguably right now, there are too many sources. We've gone from having kind of being like the Death Valley of data. There was nothing there to now it's like Niagara Falls. There's so much data coming over the edge that it's too intimidating, I think, for consumers. So what we find is that consumers are not probably using it as much as we might prefer to see them use it, and partly because I think people feel not particularly skillful in understanding this. So people are getting it and using it. There's more coming, and it's challenging right now in terms of the translation of this data into a way that is actually meaningful and useful. One of the things we do know, though, is that people who pay close attention to this data are the providers themselves. They are constantly looking and evaluating and measuring and complaining about unfairness among different data. And frankly, from my perspective, a lot of those complaints sometimes actually have a lot of validity. I mean, you have a hospital system and they are measured by so many different places, and you go to one source and they look great, and you go to another source and they look like dirt. And how does a consumer know? And so, you know, it was a proposal. It was actually made by Professor Reggie Hertzlinger from the Harvard Business School during the reform process to create kind of a Securities and Exchange Commission for health data. And we couldn't move the idea in the process. But it'd be nice to have some genuinely agreed upon accountable piece. Right now it is the CMS website that probably comes close. I don't know, are you drowning in measures over at Brigham and Women's
I have
these days?
I have to say there's a lot of public measures. Sometimes we inquire as to how those measures were achieved because they're not necessarily what we feel like represents our hospital. I still feel like folks are continuously trying to get better at data analytics and how to effectively use those measures, and how do we improve on some of the hospital-acquired conditions that you're representing when the social infrastructure isn't there, going back to that original slide that you presented.
Absolutely.
So I see a couple of questions coming through here around, we've talked about quality, we've talked about access, but now what about cost, and how has the ACA really impacted some of the projections that we should be seeing within the next 10 years around cost?
Okay. Well, that was easy. Let's go to slide 17. So, fascinating. There's a history with the Congressional Budget Office, who, by the way, I deeply admire and respect and appreciate. They are nonpartisan professionals, policy analysts, economists, and others, and they do great work. But there is a pattern. Whenever there's a big health law that gets passed, and I'm talking about since they were in existence since 1975, the creation of the prospective payment system, the DRG system in the early 1980s, the Balanced Budget Act in 1997 that did big cuts all across the Medicare system, and the Medicare Modernization Act that created the Part D drug program. In each of those three, the Commonwealth Fund and John Gable from University of Chicago went back and looked at the original CBO estimate and then looked at what actually happened. And in each one of those three cases, they looked at the original CBO estimate and what happened. And in each one of the three, the CBO was wrong. And they were wrong in each of those three cases in the same direction. And each time they were wrong, they overestimated costs and they underestimated savings and revenues. So the question would be, what would happen this time? Would it be any different with the Affordable Care Act? Well, take a look at this slide, the latest estimates from the Congressional Budget Office. What do we see? Look at the dotted line. That was the original estimate of how much the ACA would cost in 2010 when the law was passed. And then in May 13, they went back and they redid the baseline, and that's the shaded line in the middle. And now look at that darker line at the bottom. That's their new baseline for April 2014. So what do we see? We see that the pattern that we saw with the prior, it was 3 for 3. It's now 4 for 4. 4 is not statistical significance. And why is that? Well, I think the answer is because, of course, let's say Martina here is the director of CBO one of these days. I hope if you want it, you get it, right? Okay. And she's got, and tell me if she's in more hot water with Congress, if she projects the cost of a new law and she projects it here and the cost is here or the cost is here. In which case does she get hauled before Congress and yelled at, how could you be so stupid and get it wrong, versus which is it like, oh, that's great, let's go, it's Miller time, let's go have some beer and relax. Well, take a look at this chart. This is Miller time, right? Nobody's dragging the CBO saying, how could you be so wrong? They were wrong. Not because they're malicious or dumb. They're very smart. They're very professional. They're very good. But all of their institutional imperatives are to be excessively conservative. And that's what they do. And here's what we see. So good news, the ACA is costing significantly less, 13%. Now what's going on with bigger health spending? Let's go to slide 18. And take a look at this. This is from the Federal Reserve Board, just again from April 2014. So we're showing you recent stuff, but this is over a long period of time. One of the big surprises from the 4 years since the ACA was signed has been the unpredicted and unexpected deceleration in the rate of growth. Again, we're not cutting below 0. So we're not cutting, but the rate of growth has been so much less and so much less than was predicted at the time that the law was signed. You can also see though, and it's you look at this chart and you see there's a long-term trend that goes way beyond the last 4 years in a deceleration. However, yeah, that was the early part in the early 2000s. That was the economic downturn that occurred right around 9/11. You tend to see those spikes during bad periods of time. We had a really bad recession. I remember I was in the state legislature at the time. In the late 80s, early 90s, you look at that big peak there and go back to 1975. 1975, we had a wicked recession. So all of the peaks happen right around the times of recessions. And we saw just a little bit of it in 2009. But look at what's happened, okay? So, and that is overall health spending, and that reflects an unexpected deceleration both in public programs, Medicare and Medicaid, and in private programs, private insurance as well. So we are in a period now, of course, will this continue? Will this go on? We don't know. But if we're smart, we will assume it is not, and we will not let down our guard in terms of trying to move the delivery system to a better place so that we can, in fact, create a more sustainable future, because even though we're in a very good period right now in terms of healthcare costs, the long-term projections, because of the huge number of people, myself included, who are going to be getting into the Medicare program not too shortly, I'm 4 years away. How about you, Steve? How far away are you?
A bunch.
A bunch, okay. And we're not even going to talk about Martina when she's getting in there. But me, what's 4 years from now? 2018?
Yeah,
2017?
2018.
Yeah, 2018, Medicare, here I come, right? So I'm part of the problem. So that's still going on. And so we can't afford as a society to keep going with a healthcare system that grows so much faster than the economy. And that's one of our big challenges. Let's just look at a couple more slides. Slide 19. Here's healthcare and medical price inflation. Again, it shows basically the same story. This goes back to the 1960s. We see this huge expansionary period, of course, starting in the mid-60s and going through the 70s and 80s, and then this trend downward. So again, some conservatives have rightly said, listen, this downturn started significantly before the Affordable Care Act, so don't take too much credit for it. On the other hand, if you go over to the left-hand side, you're seeing a significant decrease here. And let's just take a look at one more. Let's take a look at slide 20. And this is on Medicare. So what we can see is what we expected and what's actually happening. And we're seeing this slowdown. This is on a per person basis. This is per beneficiary. So this doesn't mean Medicare spending is going down. What it means is that the per capita cost of every Medicare enrollee is going down. And it's very good news. I mean, it's very good news that this is happening. Some of this is definitely tied to the reductions in the ACA, in the Affordable Care Act. Some of it is tied to other factors as well. So that's what's going on. So right now, we have basically some surprisingly good news on medical care spending over the past several years in the midst of all of this transformation. So anyway, what's the next question?
How about long-term care and mental health? What's next in terms of other things that are not necessarily covered in the ACA?
So, I would say that mental health is covered in the ACA, not so much directly as behavioral health, but it is included in the minimum essential benefits. It is affected by the elimination of the ability of insurers to do medical underwriting and impose pre-existing conditions. It's benefited by the elimination of annual and lifetime benefit caps. So there are a host of things in there. I'd say the future of behavioral health is actually similar to what I hope to see in the future of oral health, which is significant, progressive, moving forward of integration of behavioral health with physical health, other kinds of non-behavioral health. Similarly with oral health, we really need to move toward integration of oral health with physical health as well. If not completely, far better than we do right now. Just to sort of talk about the oral health, I just saw a new study the other day that talks about the significant impact of medical care, non-attention to medical care issues, and non-attention to oral health problems, and then the subsequent costs that fling over to the medical care side. So I would say, if there's one word I would say in terms of what's the future, at least this is the hoped for future that I think makes more sense. And again, this begins to point to what is the reform agenda beyond the ACA? Because we're going to be entering a period starting next January where everybody's going to be focused on the next presidential election in the fall of 2016. And anybody running, I don't care whether it's a Democrat or Republican, is going to have to articulate an agenda for health reform. And if you're a Republican, it's no good anymore to say just we're going to repeal the ACA. And if you're a Democrat, it's no good to say we're just going to keep going. Anybody running for president is going to want to articulate a new agenda. And what is that agenda going to include? I would hope that that agenda will emphasize the word integration. Integration of behavioral and physical health, integration of oral and physical health, other kinds of integration as well. I think that is one compelling, important, valuable, potential future in terms of where health policy goes next to more aggressively move on the integration side. I don't know, what do you think?
No, I fully agree. I want to push you a little bit on value. I mean, we're seeing that accountable care organizations, this focus on quality, really bringing in costs, is bringing our healthcare system to focus a little bit more on value. Can you talk a little bit about the different payment systems that are being trialed, and again, how that value piece looks like across the country?
So the whole gestalt of Title III of the ACA and the delivery system reform is to move the system away from fee-for-service, rewarding volume and quantity, and moving it toward some kind of global, capitated, accountable, value-based care that rewards based upon quality and value and efficiency. How well that works, we are starting to see some signs, but we have a long way to go before we understand. I mean, accountable care organizations, some of them are going to do well and prosper and survive. A lot of them are going to go belly up. They're not going to. Some of them will improve quality and raise costs. Some of them may improve in quality and lower costs, and there'll be all different kinds. And it will take a lot of time before we really know. The places where we do see the really positive signs right now are the readmissions and the hospital, the healthcare associated conditions, and so forth. One of the compelling pieces about the readmissions that I don't think people really appreciate or understand is that most of what we do is either just pay for services delivered. During the last decade, the first decade of the 21st century, a lot of focus was on a concept known as pay for performance. And Meredith Rosenthal talked about that in her lecture on financing and reimbursement. And basically, the message was we didn't get a lot out of pay for performance at the end of the day. Now, the readmissions penalty is something different that we haven't seen before. Because what the readmissions does for the very first time, to my knowledge in a significant, serious way, is paying based upon outcomes. When I was in my doctoral program in the School of Public Health in Michigan in the mid-1990s, we had some of the gurus of quality who were part of that program, folks like Avitas Donabedian and Leon Vysheviansky and others. And they would say to us, you know, we wish we could pay for outcomes, but the truth is we know we can pay for the structural aspects of care. We know we can pay for process or performance, but the one thing we will never be able to do is pay for outcomes because it's too complicated and we just can't do it. We are now paying for outcomes. And frankly, if you look at, in Massachusetts, one of our other payment reform experiments from our Blue Cross Blue Shield plan, which has this thing called the alternative quality contract, which was really an early form of the kind of reforms that are in the ACA, but applied on the private sector side. Embedded in the alternative quality contract are a whole series of measures where they are also now paying for outcomes. So if I see a future, it is moving away from fee-for-service and toward value-based payment, but a significant component of that value-based payment is going to be paying providers based upon outcomes. Here's something crazy I heard that blew my mind recently, and this is in a book which I highly recommend, but from 2012 by a guy named Dr. Eric Topol. It's called The Creative Destruction of Medicine, and it's all about his vision of where consumer and patient-directed care is going. And he reports in that book that there are actually now on-the-ground experiments where drug companies, and they mention Johnson & Johnson in particular as an example in that, for certain high-cost biopharmaceutical drugs, are now getting paid for those drugs only when they work and not when they don't work.
Talk about outcomes.
So so innovation is innovation in healthcare. You know, I've been in health policy since 1985. And I will say I have never seen in those 30 years so much experimentation and trying new methods of doing things differently than I've seen in the past 5 years. There's almost too many things going on at once, because how can you tease them apart? The effect's really hard to measure what's really going on. But I don't expect the pace of innovation to go down. I think we're just starting an acceleration period, because the pressures on the spending side are so great, and the pressures are just so compelling. Anyway.
That's very exciting. So bringing it, considering this is our last session, can you talk a little bit about how do we engage and how do we continue to stay informed even after the class is over?
Thank you. That's great. I love that question. Okay. So two pieces to it. So for how do you stay up? How do you stay involved and stuff? So if you don't already do it, I highly recommend that you sign up for just at least 1 or 2 or 3 of these free daily emails that come into your inbox that basically summarize all of the important policy developments of the previous day. Mm-hmm. New studies, new things going on in DC, new things going on in states. So some of them, I kind of get all of them, or I get a lot of them. I get the Kaiser Family Foundation Daily Health Policy Report. Robert Wood Johnson sends out a daily health policy report. Politico, this is much more political and kind of gossipy, but Politico Pulse is kind of a daily news dump from DC. There are a variety of those, and you should just test them out and see which ones work for you the best. But it's kind of like, you know, you're getting into health policy. If you haven't been part of it, it's like jumping on a carousel or a merry-go-round that's moving really fast, and you've got to run to get on, and then you've got to keep up with it as it keeps going, because it's changing every day. And the longer you do it, the more you do it, the more comfortable you're going to get, the more familiar, because you not only need to understand issues substantively, you have to understand them over time and where they came from. You can understand the latest fights around Medicare Advantage, but if you really want to do it, as Joe Newhouse explained, you've got to really understand the history of where this program came and how it changed over time and why it was created in the first place to make sense. So that's number one, is just get yourself on some email source that is free, that gives you a good dump every day of what happened the day before or several days before. The second piece then is gets to you, and if you actually would like to become active and part of health policy. And the way I like to visualize it is, imagine United States health policy is like a gigantic hotel. It's huge, and it goes way up in the sky. And on the ground floor, around the street, on the sidewalk, there are like 100 different doorways into the hotel. And the truth is, it doesn't matter what doorway you walk into to get in there. Once you're inside the hotel, you can go visit the shops, you can go to the movie theater, you can hang out in the pool, you can rent a suite, you can go visit, you can go anywhere in the hotel you want. You can never see the hotel because it's too big. There's just too many pieces to it. But just sort of get in. And so what are some of those doorways into the hotel? So here are a few. If you are a health professional and you are part of a your profession's organization, chances are your organization has some group that focuses on policy. So connect with your group, whether it's a physician group, a nurses group, a social workers group. Are you part of a group?
I'm part of plenty of groups.
What's a group you're a part of?
I'm part of, in healthcare specifically,
Mm-hmm.
Well, we actually have a alumni group stemming from the program we did here.
Uh-huh.
I'm part of the American Society of Anesthesiologists because
Okay.
I work closely with anesthesiologists.
There we go. Okay.
Right. I'm part of the Massachusetts Nursing Association.
Okay. Right.
A lot of young professionals group that focus on healthcare.
Right.
Or some women's groups that focus on healthcare. So probably too many groups.
So get in with a group and get active with the group. And what you do then is you find people in the group who know this policy world so well. And some of them will take you under their wing and help you learn the ropes so that at some point in the future, you're the one helping new people along as well. So that's one idea. Another idea is to join, get involved with a citizens group. It's not non-professional related. There are a number of them. We have one here and we have a couple here. I used to be the executive director of a group in Boston called Healthcare for All. And we were for consumers and citizens who wanted to have a voice and try to influence health policy in expanding coverage and improving the quality of care. So there are those kinds of groups around. You can go and work for a public office holder. a member of Congress, a senator or a rep. You can, try to get a job working for them and doing some of their health policy work. Some of those jobs are harder or easier to get, but it's a way in, and there's nothing like working inside government to really ground you and help you understand and get some good insights into how things actually work. If you really want to get into the ground floor, pick a candidate. Pick a candidate for Congress, for Senate, for governor, for any kind of office, and be part of their campaign and get involved enough so that one of the things that you're doing, you may help them raise money, you may help them organize, you may help on policy work. Try to get involved in helping them develop their policy agenda. And then if they get elected, sometimes you win, sometimes you lose, but if they get elected, sometimes that's a nice way actually to get on the ground floor and end up working inside the government. Some other ways to do it, get involved with your political party that you identify with. Whether you're Republican or Democrat, there are opportunities to engage that get you involved, that get you active. Other possibilities, write, teach, speak on health policies, to just add your voice. It's so much easier now to create your own voice and to speak out and to get heard and to get noticed. Some people may say it's a little too easy to do it these days than it used to be, but it's so much. So if you have a voice, if you feel like you have something to say, just get out there. There are so many different ways to do it. I mean, you don't have to be on the New York Times or the Washington Post anymore. I mean, things get printed and get picked up and go all over the place in the way that was just unimaginable just 15 years ago. Last thing I would say, every one of you watching should think about, at least consider running for office yourself. Go for it. I mean, if you want to have a voice, if you want to have some influence, Now, there's lots of books and people who can coach and tell you how to do it, how to gauge your expectations. But, somebody's got to tell you the first time to think about it. Martina, I think you should think about running for office sometime. She has other ambitions, but she should think. So all of you should think about doing that. So anyway, those are some of my favorite suggestions in terms of how to become active. There are so many ways to do it, and so many of them are just so rewarding, and you can feel like you are really part of the process and helping to make a difference. So I hope that what you got out of this course is not just kind of, this is the end of the road, adios, so long, been good to know you, but I hope that you will engage and become part of the process and be in touch with me. I've heard from a lot of you, and let me know how it's going, and I'll give you some pointers here and there. Anyway, what else we got?
So do you want a choice? We're getting close to an hour. Do you want to handle 2 questions, or do you want a choice of 2 questions?
I'll handle 2 and I'll go short.
Okay. So there are a bunch on Medicaid and the U.S. Supreme Court's decision.
Oh, yeah.
And with that is the idea of, do you think it's inevitable that Medicaid will expand in these other states?
Yes.
And what do you think, what suggestions do you have to rectify this situation? Or do you think this situation needs to be rectified?
Well, it absolutely does. I mean, it's like, so understand the reality right now. Because of the Supreme Court decision on Medicaid, the only citizens of the United States who do not have some guaranteed access to affordable health insurance are low-income adults in states that have not expanded Medicaid. It's just atrocious. And yet, just like I can find a silver lining around any cloud. And so there's a silver lining around this cloud. The silver lining is that in the 24 states that have not expanded Medicaid, in many of them, there is a compelling political campaign to get those states to expand Medicaid. There are now 9 states with Republican governors that have expanded Medicaid. Not one of those governors is in any political jeopardy because they did that. The bigger picture, just to step back, is to remember, when Medicaid was created in 1965, it was also optional for states. And about 4 or 5 years after Medicaid was established in 1965, about half the states had enrolled because it was voluntary for states. It wasn't until 1972 that 49 states joined, and the final state to join didn't come until 1982. Do you know what it was? What the 50th state was to join? No?
Maybe.
What?
Nevada?
No, not Nevada. It was close, though. It was Arizona.
Oh, Arizona.
Arizona was the last state to join in 1983. So, it will take time. The financial incentives for states to join the Medicaid expansion are considerable, far more than the incentives to enroll originally. I will make the prediction within 5 years, all 50 states will be part of this. But it's not going to be a freebie. It's going to require work. And so if you're in one of those states that hasn't done it, please be part of that process and try to help make that happen, because it is smart and it is the right thing to do. Last question.
Okay, last question.
Here we go.
You have a lot of experience with Massachusetts as a model. So what can we learn from Massachusetts that can help with the federal ACA? And what pitfalls do you think that we can try to overcome? And which ones do you think are inevitable? What mistakes are we going to make again?
Well, let's take a look at slide 8.
Okay.
I mentioned this in one of my weekly emails to everybody. This was, remember Professor Ben Summers? He did the Medicaid expansion. And here's a study that he put out just a month ago in the Annals of Internal Medicine that basically document, based upon pretty authoritative county health data, that Massachusetts health reform between 2007 and 2010 actually saved lives. The estimate is about 320 prevented deaths per year, right? Not surprising to those of us who understand the dynamics and the impact of not having health insurance, but it's getting documented. So I think what Massachusetts was able to show was that this pathway, while it is far from anybody's preference, right, left, or center, actually could be made to work. And just recently, the last couple of days, there's some new data out that shows that during this recent ACA surge, that we added about another 200,000 people to the rolls of the covered in Massachusetts, so that right now in Massachusetts, the estimate is we may be somewhere under 1% uninsured. So I think what we've been able to show in Massachusetts is that this is doable, that there's a path at the other way. This, by the way, doesn't solve all the problems of humanity. People still are angry and pissed off and upset about this and that. Universal coverage is not the end. There's so much more to do. But this is so fixable and doable, and I think Massachusetts has shown that, and that's why I think a lot of us who've worked in Massachusetts are so proud to have been a part of this. So we're out of time, just about, but so let me just thank Martina.
Oh, no, thank you.
And Melissa and Caitlin. Oh my God, my mind's going soggy. And Steve and Stefan and Aaron Hawkins and Bonnie and Patrick. What's Patrick's last name?
Carrie.
Patrick Carey. And any other tech people we need to thank.
Sarah Beers.
Sarah Beers. Anyone else?
No.
Okay, so many people helped to make this happen, and we know you've gotten annoyed at various points with the bugs in the system, and we sincerely apologize for that. I'm mortified at it. I'd feel so embarrassed, and I'd call Steve in the middle of it. What's going on? Blah, blah, blah. But anyway, it's been a great journey. We've really enjoyed doing this. It's been really exciting. And I guess there's another couple of weeks that people will have to finish this.
Absolutely.
Until July, Independence Day,
Yeah,
July 4th or something like that.
Yeah.
It'll be on the
We'll
website.
send an updated letter.
And we'll send an updated letter next week. So, this is the end.
This is the end.
Thank you, Steve. Thank you,
Thank
Martina.
you.
Excellent. Great. And thank all of you. Nice to see you all.
Great.
Bye-bye.